Thank you, Dean, and all the work you do for our HLRCC patients. So my name is Marie Carlo. I'm a medical oncologist at Sloan Kettering, and I'm very excited to kick off our Papillary RCC session. It's a tough act to follow wood fire, but I think we have a great session ahead. So first, I'd like to call up on the stage Dr. Swice. He will be talking about updates on basic science updates in papillary RCC.
I'd like to thank Dr. Carlo and the organizers for the opportunity to present today. I was tasked with discussing basic science updates, and then as I'll come to later, we've had quite some challenges, I think. It's been inspiring the last few days to hear from patients and organizations like HLRCC, and I think that kind of reminds us what we're doing in the lab has actual meaning, and I think there's a lot of efforts that we can go for papillary RCC. So first of all, we need to talk about definitions, and these have evolved over the years. As many in the room are aware, about 20 years ago, the definitions were type 1 and type 2, and this was defined mostly based on histopathology and morphology of the tumors as they looked under the microscope. Type 1 had lower nuclear grade and had papillary architecture, and type 2 was associated with eosinophilic pattern and higher grade nucleoli and generally had worse prognosis. Over the years, we began doing molecular sequencing, broad molecular sequencing of tumors, and about 10 years ago, we started to identify molecular alterations associated with different papillary tumors, and this was the TCGA, which classified, the original classifications of type 1, type 2, and unclassified are shown among the about 150 or so samples. And patterns of molecular alterations emerged, such as chromosome 7 gain in papillary 1, type 1. And then more recently, the pathologic diagnosis is based on a combination of many factors. And in particular, these molecular features are now included, and many of the type 2 and unclassified papillary RCCs are now defined based on these molecular features. But still, some are canonical papillary renal tumors, and we call those papillary renal carcinomas, and those are traditional MET-driven tumors, but others have been moved into these molecularly defined carcinomas on the bottom, such as the FH-deficient RCC and TFE3 rearranged renal RCC, for example. So there's been an evolution in these definitions, and I think we're learning a lot more about the subtypes of these tumors. So going back originally about 10 years ago, this was when MET was identified as a driver in type 1 RCC. This was a paper that showed, on the left panel shows the amplification, and on the y-axis and the x-axis is gene expression, and showing a correlation between regions that were amplified and gene expression, and you can see that's correlated. There are some samples that have gene expression even without higher gene expression even without amplification. And then panel B is the papillary type 2, and panel C is the papillary type 1. And you can see red is copy number gain. And in particular, the 7q31 region is amplified in almost all, over 80% of the papillary type 1s, and that's where the MET locus is. So this is sort of the first big population of patients and tumors that were evaluated to identify MET. Then TCGA came later that showed, again, that MET indeed clustered with type 1 RCC. There's a whole multi-omic array of data that came with TCGA, including methylation, but when you do unsupervised clustering just based on copy number gain, you find these three clusters, the top showing genome stable sporadic scNAs with a few chromosome 9p deletions. The middle is the cluster that is the MET-driven papillary type 1 RCC with chromosome 7 gain, and the bottom is this genome unstable chromosome 9p deleted. So, and then we see these particular specific genes on the bottom that are associating with papillary RCC in high frequency, but maybe more with type 1 versus type 2, for example. The MET we know about, and then NF2 more prevalent in type 2, for example. So this is with copy number gain and loss, and then when you also look at methylation, you can do unsupervised clustering, and you find these three clusters as well. Cluster 1, cluster 2, cluster 2 actually corresponds to the papillary type 1. Cluster 1 is some mix of type 2 and unclassified, and then you see this CIMP, this CpG island methylation pattern cluster that's this smaller group that's associated with a younger age and poor prognosis, as you see on the survival curves to the right. And when you look on the left, you see that the FH expression is lost in those patients, so that defines that subgroup. And then finally, when you have all of this data that's sort of overlaid on itself, you can perform a cluster analysis and basically get to 4 distinct clusters of papillary RCC. That's C1, C2A, C2B, and C2C. So C1 corresponds with the MET-driven type 1 papillary RCC. C2B is a mix of unclassified and type 2, but predominantly type 2. And it's the C2B and C2A and C2B are both type 2, predominant type 2 or unclassified, but there are differences in stage. It seemed that C2B was a higher stage and had worse prognosis. And then the CIMP is again defined here as a smaller cluster with the worst prognosis that was associated with the FH mutation. So all of this genomic data has really informed our classification, and then other data sets have confirmed this. This is Mani Paul's and colleagues who published this data set looking at the specific alterations found in papillary RCC, and of course we see the MET kinase domain mutations. These are typically activating mutations, and they're mostly prevalent in type 1 RCC. You also see some differences in the right showing like NF2 more prevalent in papillary type 2. So the data is sort of showing very similar findings and confirming in an independent data set that what we now know about the different subtypes. But importantly, I think in the era of immunotherapy, we also want to know about what does the immune microenvironment look like. There's a lot of ongoing efforts in this particular subtype, and certainly in clear cell, but even in papillary we're seeing emerging data. But I want to sort of first step back to the chart that you've seen a million times with the tumor mutational burden, and this is obviously not necessarily reflective of the immunogenicity of the tumors, in particular in kidney cancer, because of the things that have been discussed today, like human endogenous retroviral expression and different truncating mutations and frame shift mutations. But what we see is that actually papillary and clear cell fall right next to each other in terms of the median tumor mutational burden. But importantly, with this, whenever people show this chart, it's important to point out that even if you look at the variation within tumors, you can see, for example, some melanomas that have lower tumor mutational burden than glioblastoma. In some cases, there's a wide variation within a tumor type. But anyway, just to sort of level set, the mutational burden is very similar between the two. But what's important is the immune microenvironment can, of course, influence immune responsiveness. And our lab and others have shown that there are different phenotypes in various cancers that are associated with T-cell inflamed or non-T-cell inflamed tumors, and these can be identified by gene expression profiling, immunohistochemistry, now spatial transcriptomics. We see in some tumors this inflamed phenotype which has dendritic cells, T cells, a particular type 1 interferon signature. There are over 160 different signatures that are in the literature on immune phenotypes. So this is just one particular one that's pretty narrow that is looking at T cells and this type 1 signature, and I show it on the right. But you can see that there is clustering between different samples. That by principal component analysis, you can see separation. What's unique about clear cell RCC is that the inflamed tumors may have a different clinical correlation. But so with this, you can actually generate a similar plot where instead of tumor mutational burden, you're actually looking at the T-cell inflamed signature across tumor subtypes. And here, all of a sudden, you see a big divergence. Clear cell is actually the most inflamed tumor by this signature, and the vast majority of patients have T-cell inflamed immune phenotypes. And this is consistent with data that PD-L1 expression is generally prevalent in most kidney tumors. But papillary is different. Papillary actually has a pretty big variance with almost split a third between T-cell inflamed, intermediate, non-T-cell inflamed. So that's kind of interesting and probably reflective of the fact that there are different tumor oncogenes present within the different subtypes of papillary it's more than one disease. But important to think about as we develop new therapies. On the Other groups have looked at immune score, and this kind of gets to the point. This immune score and stromal score are derived from gene expression profiling data, and the high expression of the immune score actually is associated with poor prognosis, which is paradoxical compared with a lot of other tumor types where you actually see an improved phenotype, and I think the same finding is with PD-L1 expression. Similarly, with stromal score, high expression is associated with poor prognosis in papillary RCC. So looking under the microscope with immunohistochemistry, you can define different immune cell populations, and this paper looked at particular subsets of CD8 T cells, and you see, as expected perhaps, that intratumoral lymphocytes with high Ki67 or proliferating CD8 positive T cells in the tumor are actually associated with poor prognosis, again, confirming the gene expression profiling data. But what's interesting is, what's interesting is that the peritumoral lymphocytes, CD8s in general, are actually associated with favorable prognosis, and the CD8 FOXP3 ratio does seem to lead to a favorable response, which is consistent with other tumor types. So there are a lot of paradoxes and questions, I think, that come out of this. Myeloid cells are obviously important and not really evaluated in this particular paper. And I'm encouraged to see there's work on this being done. I saw the poster from Moffitt that had spatial transcriptomics and other information looking at myeloid cells as well. So congrats to the authors there. But when we go back to the lab to try to figure out what to do with papillary RCC, I find there's actually quite a paucity of models, and I think we've learned a lot in many cancers from preclinical models that's helped inform the therapies we move forward in clinic, rather than simply using the therapies that are available for clear cell and giving them to patients with papillary RCC. So this review kind of summarizes the models. There's quite a few for clear cell, some for chromophobe, but you can see ND is no data, and so there's a syngeneic model, no data. There's a MYC overexpression gem model that actually I think was originally a clear cell, but it behaves more, the genetic profile is more of a papillary, so it's sometimes used. And then the FLCN gene knockout is a gem model. But otherwise, there's no chemically inducible models, and the CDX models are also oftentimes derived from clear cell but just have molecular phenotype that might be reflective of papillary RCC. And all of those are human-derived, which is important to learn. One of the challenges is we can learn about intrinsic tumor biology from these tumors, but we can't really learn as much, I think, from in terms of the immune responsiveness to the tumor in the lab, because these require immunocompromised mice. So I think, again, from immune deficient mouse models, we can learn about resistance to TKIs, and there's a lot of things that have emerged from that, and so that's important work. But I think one of the big challenges is to develop syngeneic mouse models for papillary RCC, different subtypes of papillary RCC that we can actually begin to evaluate, not just the immune responses, but perhaps the effect of TKIs or other combination therapies on the immune responsiveness of the tumor. So with that, I'll summarize by the diagnosis of papillary RCC has evolved over time, and I think our pathologic diagnosis now is much more refined based on molecular features. Translational data have shown important pathways like MET in papillary type 1 or now just papillary RCC, and it's also associated with a less T-cell inflamed tumor microenvironment than clear cell RCC. And I'll just close with a plug for any graduate students that are around or fellows that want to develop a project. I think we need syngeneic models for papillary RCC.
Thank you. Our next speaker is Dr. Ben Mon from Hudson Cancer Institute. He'll be speaking about clinical trial updates in papillary RCC.
No one's joking. This really is bright. So it's really an honor to be here today and talk to you about this topic. And in particular for me, it's really an honor to be here because I'm quite inspired by this organization, KCA. I think they've done a tremendous amount for all of these diseases that we're so involved with. In particular, if you think about how much effort and focus they really put, not only in the most common disease, clear cell, but all of these variant histologies. It's quite impressive what they've been able to accomplish in collaboration with all of their affiliate organizations. So today we're going to be going through and talking about what I think are the practice-informing trials about papillary kidney cancer, and then also exploring and seeing what some of the current clinical trial landscape looks like for this disease. Because I think understanding what those clinical trial landscape looks like really tells us a lot about how we can move forward with any of the variant histologies that we see and treat. So how did we get here? Well, as we all know, this was originally the first real study that showed some significant clinical difference, specifically for patients that have metastatic papillary kidney cancer. It was led by the inimitable, Dr. Monty Powell, who can't be stopped. So he moved forward with doing this, what I think is a pretty complex trial for a rare disease. So he decided, not only am I going to compare two things, but I'm going to compare four things in a rare study, which really, I think, helps me understand that not only are clinical trials doable, but we can ask pretty important and complex questions, even in the context of a rare disease. So in SWOG 1500, they compared the four arms, and as we know, two of the arms failed to show an improvement over what was considered at that point the standard of care, sunitinib, in the interim analysis. And so they were discontinued early, hence the much smaller sample size that you can see for both crizotinib and savolitinib. So there was a significant improvement with cabozantinib in terms of PFS. There was no statistical improvement in terms of overall survival, largely limited based on the very small sample size. So this really established cabozantinib as the standard of care for this disease. But happening in parallel at the same time and published almost at the same time was the work from the Keynote study looking at monotherapy with pembrolizumab. And even though this was a basket trial for variant histologies, very importantly, they planned and showed us the results based on the disease-specific cohorts. So if you look at the papillary cohort, the characteristics are pretty similar to what we see, or response rates are pretty similar to what we see with clear cell kidney cancer. If you'll note, the progressive disease rate is 38%. Again, very similar to what we saw in the Checkmate 025 study with nivolumab in metastatic clear cell kidney cancer. The objective response rate, again, very similar between what we see with papillary kidney cancer and clear cell kidney cancer. So this demonstrated that there clearly is some measurable significant activity with checkpoint inhibitors, specifically PD-1-based checkpoint inhibitors in papillary kidney cancer. And so this led to a significant, at least for a rare cancer, explosion of clinical trials looking at the combination of IO-TKI therapies. And instead of showing you each one individually and going through a barrage of slides looking at Kaplan-Meier curves, I thought I would summarize it very succinctly with this table. And I just ordered them in terms of sort of publication chronology. So the first one was the phase 1 study of Cosmic 021. Note the caveat in terms of a lot of this published data is a coalition of all of the variant histologies together, not specifically papillary, but the majority of the data is driven by papillary patients, since they represented a significant proportion of the total of the variant or non-clear cell histologies. But as you can see, it had a very respectable response rate of 47%, and the median PFS was significantly inferior to what we see with many of the TKI-IO combination studies in clear cell kidney cancer. Admittedly, though, this was not necessarily their first-line therapy. So this was followed up by a couple of other specific trials. Joe Lee led the study of cabozantinib and nivolumab. This was similarly for 0 to 1 prior TKIs. And of note, the light yellow bar underneath, I'm just trying to highlight for those patients that are first-line therapy. We don't have a lot of data, so there's a lot of missing boxes here, but anyway, it also showed a very respectable objective response rate of 47%. And I didn't highlight it, but in the previous slide, I did, as sort of like a reference point, the objective response rate for cabozantinib in the SWOG 1500 trial was around 25%. So again, a very healthy response rate with a median PFS of 12 months. We see in the most recently published study from Laurence in terms of the Keynote B61 trial, this was all the patients were treatment naive. The IMDC distribution was pretty similar to what we see, although a slightly higher proportion of favorable risk disease. But it showed an objective response rate, again, right around 50%, specifically 54%, and it showed a quite impressive median PFS of 18 months. So what does all this tell us? Well, these are effective therapies that we can use for this disease, but how does this stack up against what was admittedly the, at least based on evidence, the standard of care of cabozantinib monotherapy? So I think it's important to take a moment, pause, and appreciate some past lessons we've learned, specifically in kidney cancer, that a number of phase 3 trials have demonstrated that what we thought from earlier phase data, phase 1, phase 2, ended up not being effective in terms of immune therapies, very recently with the CONTACT-03 trial, and also with the CANTATA study led by Dr. Tanier. So even though we can have some very promising preliminary data, oftentimes these single-arm, sometimes single-institution studies, as we all know, very much exaggerate or not truly, it doesn't give us a very accurate representation of the true magnitude of the effect of the therapy, perhaps due to a lot of biases such as patient selection bias, et cetera. So where does that leave us today? So what this has really demonstrated, not only to me, but it appears to the entire field, is that not only are our clinical trials doable for this rare disease, but randomized trials are definitely doable, because there's a significant number of them that are currently ongoing in this specific disease space. So in terms of the randomized phase 3 trials, there's the SYMITA trial and the Stellar 304 trial, looking at TKI-IO combinations versus a TKI, or in the case of SYMITA, the third arm is also IO therapy. This will be particularly helpful for all of us, this data, to tease out what is the exact contribution from each of these components, and are we really going to see some synergistic effect with the TKI IO therapies. And this is, I think, quite impressive and interesting, because this is not an approach that we've really taken even in clear cell. Obviously, as you all know, I'm also leading the PAPMed-2 trial, so we're putting a plug in for that here, where we're comparing cabozantinib versus atezolizumab. This also gives us an opportunity to see if there really is a difference, once we have the data from all these trials, if there really is a significant difference between PD-1 therapies and PD-L1 therapies in this specific disease of papillary. And then, again, specifically because I think we all care the most about PAPMed-2, right? Unless we're in France, Laurence, and then we can care about Paxipem a ton. This is one of the trials that's currently going on. I really appreciate all the help that many of you have contributed, both in terms of protocol development, encouraging patient participation, et cetera. The primary endpoint for this trial, similar to many of the other trials, is progression-free survival, and overall survival is a key secondary endpoint in both this trial and also many of these other randomized and single-arm studies that are ongoing. The enrollment is actually, I think, an important thing to highlight, not only for PAPMed-2, but for the other phase 3 randomized trials. Each of these are looking at taking an ambitious enrollment goal of approximately 200 patients. And so once we collect all of this data from all of these trials, this is going to be a wealth of data that our entire community has available to do a lot of biomarker research and basic pathology research. So, in summary, cabozantinib currently, at least based on randomized data, is the proven standard of care for metastatic papillary kidney cancer. But, in my opinion, there's reasonable evidence based on a number of prospective, well-designed prospective studies to also consider and support the use of combination therapy. And it's important, I think, though, to really have a randomized study so that we can truly see the difference and the effect on these therapies. Is intensified combination therapy truly more effective than sequential single-agent therapy, et cetera? And additionally, participation in all of these clinical trials will allow us to collect a rich, robust data set so that we can really help the field move forward with our next generation of clinical trial enrollment. Thank you.
Thank you. And finally, we're going to hear from Dr. Brett McGregor from Dana-Farber. He's going to talk to us about lessons learned from the CAN-I trial.
Thank you very much on behalf of the Organs Committee for the opportunity to speak with you today. So I was tasked with talking about lessons learned from CAN-I. I don't think that's really the right title, so I think it's lessons still learning from CAN-I, right? Because we do these trials and we never stop learning about what we did, and there's always so much we can do. These patients gave us their time, put their trust, and I think that this is something that we can continuously learn from as we go forward. So learning objectives, treatment for renal cell carcinoma with variant histologies is finally evolving. We can enroll on trials in a space and learn from every patient, even from what may look like a negative trial on first glance. So, I'm the last person, so my slides are done, and then you hear the talks and realize, oh, there's some things I already talked about. So when we think about variant histology, I'm not going to focus just on papillary. It's easy to say, oh, well, what was the treatment back in 2017? And we had studies, and we had sunitinib was better than everolimus, and we say, okay, that's the story, but there's actually so much more to the story than just what treatment was available, because back then you had the slides like, oh, there's non-clear cell, and there's papillary, and there's chromophobe, and it's unclassified. And now, I don't know, I get like 1 million different pathology emails with a new diagnosis I haven't heard of every day, and it's a question of how does that all come into play, and how do we think about treatment? And now, as we just heard from Ben, there's really a lot of studies that have shown that we're making advances, and maybe 2 is better than 1. I think we agree. We need some randomized trials, but we have data for Len-Ev, with response rates around 15% in papillary, 44% in chromophobe, really exciting. We have data with nivo-ipi, with the response rate overall around 20%, maybe a little higher in papillary, atezo-cabo, cabo, nivolumab, len-pembro, so really a lot of excitement. And so, with all this excitement that's been there, as COSMIC-313 was being developed and everyone was like, this is going to be the next big thing, take nivo-ipi, take away that 20% PD's best response, add in the cabo, the thought is, well, variant histology is just the worst. And so this is where we can really think about it. So this was the basis for the cabo, nivo, ipi, or CAN-I trial. So we took patients with metastatic renal cell carcinoma with variant histology, treatment naive, 1 prior line of therapy, and we gave patients the cabo, nivo, ipi at the sort of the COSMIC-313 dosing, right? So cabo 40 milligrams daily with ipi 1, 3 weeks, nivo 3, Q3 weeks, did the 3 months, and then we assessed, and then we continue with cabo and nivo. Our primary endpoint was objective response rate per RECIST 1.1. So lesson 1 of CAN-I is we can enroll in these trials when we work together, right? So this is looking at variant histology. We only did this in less than 5 sites, but within that time, just over 2 years, in the middle of COVID, we were able to enroll 40 patients with variant histology renal cell carcinoma. And so I think it shows that when we commit our resources and work together, this is a place where we can make a difference. Looking at the baseline demographics here, the key things I want to point out from the trial is that a majority of these patients were intermediate risk disease, and we had a variety of histologies. And, I think it's important to note, we just say papillary. We now know all these papillaries are incredibly different. Chromophobe, translocation, and we had a decent percentage with sarcomatoid differentiation at around 23%. Treatment exposure overall, I think, as would be expected, there was toxicities, and subsequently, a lot of patients didn't go through the 4 cycles of nivo-ipi, although 44% did. 24 patients went on to receive nivo maintenance. We did not require you get all 4 doses of ipi to go on to nivo maintenance. A majority of patients required dose reduction, 72% to 20, 18% to 20 every other day. So that tells you 10% that were able to stay on full dose. I think what's important to note here is that 14 patients continued on therapy at time of analysis. So what are the responses? I think overall we were all hoping for better. Objective response rate 18%, disease control rate 76%. And we didn't see one subtype that really responded better than the others or didn't respond overall. Again, we get into quite small numbers when we start looking at the translocation and the other. I think it is important to note that, the translocation had responses, but we had decent stable disease with a lot of patients shrinking. When we start looking at presence of sarcomatoid differentiation or not, really wasn't super helpful. Prior therapy, it seems to be that, we have more responses. We didn't have any responses who had prior therapy. PFS, OS, really, really short follow-up. And 6-month PFS, 68%, 12-month, 51%, with a 12-month overall survival of 80%. So what's lesson 2? Well, we look at Cosmic 313, and we saw that the response rate was right around 40% in Checkmate 214, and it wasn't that much better when we added cabo. So, the lesson there is cabo doesn't increase objective response rate when added to nivo/ipi in clear cell, or now we know in variant histologies. And we take a little bit step further back and say, well, look at that Cosmic 313. Is there any other things? And specifically look at those patients with poor risk. That's where there really didn't seem to be that clear benefit to adding cabo. And if we start thinking about all these variant histology patients, we generally think that these have worse outcomes. They're tougher to treat. And so when we then take a step back and say, well, what have we seen for nivo/ipi overall in the variant histologies? This is from Checkmate 920. And we see a response rate around 20%. So, not that different from the 18% we saw with CANI. So if we didn't see an improvement in response rate in 313 in this large trial, can we really expect to see that in variant histology? Obviously, we didn't know that when we designed the trial. But I think what I would point out is, yes, this response rate is low, but the median duration response was not yet reached at the time of this analysis, and 8 of the 9 responders remain without reported progression, which gets us to the lesson 3. Was objective response rate really the best outcome for a trial when we're looking at ipilimumab, and what is the role of ipilimumab in disease? And I think for durability, we really need longer follow-up. And so this is why you haven't seen a paper, because I think we're going to do another data lock with longer follow-up and really see, does this make a difference in long-term response? 13 patients remain on therapy at the time of the analysis. And I can tell you I have a patient who traveled from Saudi Arabia for 2 years, every 3 weeks and 4 weeks to get therapy. He has FH-deficient RCC, peritoneal carcinomatosis, and he's in a CR, and he's now on cabo maintenance. Doing well. I have another patient with liver mets unclassified who's doing well. So, the response rate doesn't tell the whole story. There's some patients who do incredibly well. But lesson 4, it's toxic. I mean, we saw that with Cosmic 313. We saw that 100% with CANI, 100% at any grade toxicity. 74% with grade 3 or 4 treatment-related adverse events, about 36% had LFT issues. And I think what was really notable is there actually was some cardiac concerns, and so we had more cardiac issues than we saw with Cosmic 313. And if you sort of look at some of the data from nivo/ipi and the variant histologies, we saw a similar pattern where there seemed to be a little bit more toxicity. Why is that? I don't know, but it certainly was toxic. So where do we go from there? I can say that no one would disagree that cabo, nivo, ipi at a dose of 40 milligrams is not the answer in RCC with variant histology. But I think there's a couple things you can do. One lesson I have on here is we need to learn more, right? So these patients, not only did they put their trust in us and do the therapy, they did biopsies and they did blood work. And so we need to go back and look, where are there signals of response, right? This is a very diverse group of patients. And so I think we're going to work now with David Braun and others to try to say, is there responses? Like what makes those patients unique? Why did that patient who's coming from Saudi Arabia, why is he still on therapy? And then the next point is, yes, that dose doesn't work, but we need to adapt. And so we had already been approved for a trial up to 60 patients when we did this. And so when we saw the first 40, we said, listen, this is not a sustainable effort, but what can we do differently? So can we change the IPI frequency? Can we do anything? And so we ultimately, after a lot of discussions, elected to try a lower dose of cabo. So cabo 20 milligrams up front with IPI. And then if you do well at the 3-month point, you can then increase back up to 40, another 20 patients. And again, this has been going on for less than 9 months, and in those 9 months, we've enrolled 16 patients with less than 5 slots to go. So again, highlights that we can do this when we work together. So we take a step back and look where we are. I think we saw these nice tables, and here we see in graphic formation that we've made a lot of progress. Response is different overall, and I think that really we have these 5 different colors for each trial, but there's probably should be 20 different colors because there's so many different types of these variant histologies, and we need to learn more about each one of these individually. So we don't just get to histology-directed therapy, but sort of like molecular-driven therapy. Like, what is the driver in these situations? And that will hopefully be done through ongoing work with upcoming trials. So take-home messages: Cabo-nivo-ipi is not ready for the clinic yet, probably never, but I think we're going to see what the trials show, and we're going to really try to learn everything we can for those patients that put trust with us, and we need to continue to support trials to advance care. And so that, I want to thank all the patients who put their trust in us and the numerous sites that were involved in this study, and I want to make one final plug. Tony is not here, he's in China, but Tony is running for the ASCO Board of Directors. He's been an invaluable mentor to me and a lot of people probably in this room, and I think he'll be a great advocate for all of us with ASCO and for the kidney cancer community, and I would encourage you, if you haven't voted, to get into the ASCO website and place your vote for Tony for the Board of Directors. And with that, I thank you for your attention.
Thank you. And I think we have we're running behind, but maybe 5 minutes for questions. Laurence?
So we do need to vote for Tony and for Kim, both of which are applying. So I have a question for you, Brad. What do you think about the sarcomatoid non-clear cell piece that you just presented? We discussed that yesterday during the CME event. You feel that we still stick to the doublet IO strategy in those patients, or we should move away and go back for a TKI IO in non-clear cell sarcomatoid patients?
I mean, I think we need more data. I mean, I think that the TKIO data is compelling. I don't know. We don't have data. I haven't seen data for nivo-ipi in variant histology sarcomatoid. I think that IO is probably important in those patients. More trials are needed.
Ben, question for Ben. Ben, you, in your slide, at the end, the take-home message, you started with the first bullet: cabozantinib is standard of care for patients with papillary. And I agree with you. I mean, that's from the PubMed. But can you comment on the trial that's sponsored by Exelixis that has the Zanza XL092 plus nivo versus sunitinib? Is sunitinib an appropriate comparator?
Yeah, that's a great question.
I know you did not design the trial, but putting you on the spot to comment on the design. And you can be like Dr. Walt Stadler, so you can.
Fair enough, yeah. So I think based on the data, I guess to be succinct, I think optimally it should allow for cabozantinib as the control arm.
No.
So same kind of questions as Nizar in terms of designing trials. So how many negative trials with atezo do we need before stopping using atezo in kidney cancer? So who wants to answer this question? I mean, I cannot understand why we are continuing designing trials with atezo when we know that it's not a good drug in kidney cancer. So why do you do PubMed 2?
Fair enough. So I think the true answer to that question is really going to come out once we have the TiNivo-2 study, because I certainly respect and appreciate that the general sentiment in the field is that there is a distinct clinical difference between PD-1 therapy and PD-L1 therapy in terms of kidney cancer, recognizing that the data is largely coming from the clear cell population. However, if you look at many of the differences in these trials, and also you look across other diseases as well, I would suggest or potentially humbly argue that the responses are quite distinct and not consistent, right? So in lung cancer, for instance, there's data of a PD-L1 therapy working in the situation where a PD-1 therapy is not. So I don't know that we've truly been able to answer that question. I think in kidney cancer, we're going to get some more information when the TiNivo-2 study reads out, because if there really is a difference, then perhaps there's more credence to that than perhaps some people like myself are believing in. But I think if you look at the context of all of the ongoing clinical trials that we have in papillary, the randomized trials that we have going on in papillary, it includes both PD-1 and PD-L1 therapies, which will allow us to both answer that question in a more definitive way, I mean, as much as possible with the cross-trial comparison biases, but also answer a lot of other questions. So even if we know that there's no difference with atezolizumab, for instance, collecting these patients on the trial and having prospective clinical data sets and biomarker registries is what's really going to drive the field forward. So in a much more profound way than single institution retrospective studies have been able to do for us so far. So I think that participation in all of these clinical trials is important and warranted.
We're with you, Ben. We're with you. I'll give you an easy one. Why the 60 milligrams of cabo in that regimen versus 40?
Yeah, that really came down to a practical consideration. So we know with these TKIs in isolation, in monotherapy, there is a strong dose-response relationship. And certainly when you're talking about adding them together, the great hope is that there's some immunologic synergy, although I would argue we're not necessarily seeing strong evidence of that to date. So because we know with the TKIs there's a direct anti-cancer therapy effect that is related to the dose, to try and avoid as many potential scientific complications as possible, we elected to start with the higher dose. Admittedly, we also know that there's a very strong dose toxicity relationship, so we're expecting there to be a fair number of dose modifications in both arms of the trial.
I have two questions, thanks to all of you. First, for Brad, congrats on pulling this off. We've talked about this before. It's a real challenge. As you go into, or as you went into the expanded portion of adding those 20 patients, considering the toxicity, was there a consideration to pull out those variants where you hadn't seen efficacy and focus on those where you saw responses?
Yeah, we thought about that actually, but if we looked at it, we couldn't find any place where we saw no responses. Like we had a chromophobe patient with a response that was quite durable, and so we went back and forth about this overnight. We talked about it amongst investigators, and at the end, we didn't feel there was enough there to say there was a group that wasn't responding, that we didn't want to continue exploring this.
And then to Randy and Ben, great overviews. Thank you so much. I couldn't help notice going from the first presentation that sort of very eloquently walked us through a better understanding of the molecular subtypes into the second one, which is a great overview, but leaves us with a protocol which ignores those subtypes that we've now learned about. So, and I understand the limitations of sort of thinking through that, but I want to hear in a perfect world, if you were to dream big, how would you set up a trial for papillary that reflects this? And I'll make one other comment is I noticed that some of the ongoing larger efforts exclude FH deficient patients, and I don't think they are excluded because we think that the mechanism doesn't work towards them. I think they're excluded because the industry-sponsored are worried that they're too sick to show a good signal on their trials. So molecularly stratification, how would you do that?
I'll just respond. That's a great point and great question. I think I'll respond with a more general answer, and that I think all of that molecular data we talked about, and we come back, not only are we then ignoring it in terms of the trial design, but we're also ignoring it in terms of the therapies we're using. Right? Everything is the same drugs, as I said, coming back to what we use for clear cell. And I think fundamentally we need to design better drugs that are molecularly targeted. And those are even harder trials to do because they're subsets of kidney cancer patients, but I think the task is on us to figure it out.
If I may just chime in. So we just published in GITC our immune characterization of papillary RCC 4 days ago. And what we are doing now is prospectively validating this data in the PAXIPEM study led by Sylvie Négrier. So to some example that may tackle this question. Thank you.
Question on the cabozantinib 60 milligram dose. Did you write anything into the protocol for early stopping rules or early interim analysis for toxicity to make sure that you weren't treating an excessive number of patients and having a lot of treatment interruptions and things? Thanks.
Yeah, thank you for the question. Similar to the strategy that seemed successful with PAPMET-1, we do have a interim analysis planned for stopping.
Thank you, everybody. I think we've gone way over time, but if, oh no, not too bad. If I can just call Salvo to the stage, he has a quick announcement, and then we'll break for lunch.